Good evening, everyone, and welcome to today's wonderful evening with Dr. Murli Bharadwaj. Every day we have a subject wise mock test and a live discussion. Please do join. Also, invite your friends, drop a line in your social WhatsApp groups that the live class has started. And every day we discuss 100 questions and totally 10,000 questions in 100 days. Very nice to see Meghaswara and many more. Can you please punch? Is the voice loud and clear for all of you, doctor? Now, blood pressure 150 by 95 is classified according to the JNC 7 as a stage 1 hypertension. So normal pre-hypertension, stage 1, stage 2. Stage 2 is more than 160 over more than 100. So these values are very, very important for the examiner. Thank you, Ravinder. Loud and clear. Now, what is an exacerbating factor for hypertension? Polycythemia, alcohol, obesity, everything. Always high sodium, low potassium. These two are the exacerbating factors of hypertension, is what you need to remember. So, what is meant by Liddle syndrome? Liddle syndrome is a condition normally if aldosterone is produced. What will happen? The epithelial sodium channels open up and sodium get retained. So, Liddle is a gain of function mutation. There is a mutation that lead to gain of function. Even without aldosterone only, the sodium channels remain open. Because of that, the sodium is retained, potassium is lost. There is a hypokalemia, not hyperkalemia. It is autosomal dominant, it is early onset hypertension. And because sodium is retained and there is a high sodium levels, typically that will suppress the aldosterone. So low renin, low aldosterone will be there in the people who are having Liddle syndrome is what you should remember. Very good to see 6 online classmates. Please inform all your friends that the live class has started. So every day, once we are practicing at least 100 questions of discussion every day, that will increase our preparedness for the exam. So nice to see Sumant and many more who are all online. The most common cause of secondary hypertension is renal parenchymal disease. Renal vascular hypertension, when do you consider? Whenever hypertension is resistant to 3 or more drugs, you use metoprolol, you use telmisartan, you use hydrochlorothiazide. In spite of more than 3 drugs to the maximum of their dosage is used. Still, if hypertension is there, which is resistant, then you consider renovascular hypertension. Similarly, any atherosclerosis of the aorta or peripheral arteries is there. If there are episodes of pulmonary edema, you should always think renovascular hypertension. Flash pulmonary edema keep coming with abrupt rise of the blood pressure. And any hypertension before 20 or after 50, there is atherosclerosis into the renal artery. That's the reason it can be renovascular hypertension. Below 20, fibromuscular dysplasia can be there. So any onset before 20 or after 50 is considered to be hallmark of the renovascular hypertension is what you need to remember. When is the first heart sound diminished? In mitral stenosis, short PR intervals, first heart sound is accentuated. Whereas whenever there is any LV dysfunction or mitral regurgitation, in all that the first heart becomes softer, is what you should remember. What is the cause of renal artery stenosis in a young individual? Always it is the fibromuscular hyperplasia. So you are evaluating Conn syndrome. What is Conn syndrome? On the kidney you have adrenal, that is the suprarenal gland. Suprarenal gland produces adrenaline, right? So typically, and also there is aldosterone production by the suprarenal gland. Cons is the adrenal adenoma, where there is a very high aldosterone levels. So how will you document it? You will look for the serum assay of aldosterone. But if you give beta blocker, colonidine, ACE inhibitor, anything can also affect the renin-angiotensin system and can cause altered aldosterone levels. That's the reason, if you want to prove that in this given patient there is a high aldosterone, you want to prove that there is Conn syndrome, first withhold these antihypertensives, ACE inhibitor, clonidine, beta blocker, and typically once you withheld them, at least a week, then you do the sampling, and aldosterone renin ratio of 30 and the plasma aldosterone more than 15 is considered to be the diagnostic finding in Conn syndrome, is what you need to remember. What is meant by paradoxical splitting? Normally A2 comes first, P2 comes later. But whenever there is any aortic stenosis, A2 get delayed. Whenever LV failure, A2 get delayed. Any left bundle branch block, A2 get delayed and P2 comes first. And that lead to paradoxic splitting, where P2 comes first, A2 comes later, is what you need to remember. Very good to see 11 online classmates. So doctor, with regard to coarctation of the aorta, it is associated with bicuspid aortic valve. Usually it presents with systemic hypertension. The infants who have coarctation of aorta may have severe heart failure. So what is meant by coarctation? Coarctation is narrowing of the aorta. When the aorta becomes narrowed, there is a decreased blood flow to the femoral vessels and there is a diminished pulse in the femoral pulses, not a bounding pulse, is what you should remember. With regard to the coarctation of aorta, ECG shows left ventricular hypertrophy. In severe coarctation, there is a continuous murmur. Some of them, coarctation of aorta is associated with Turner syndrome. That's the reason webbed neck may be there. But if you look at the diastolic pressures will be equal in both the upper and also lower extremities. Only systolic hypertension pressures are higher in upper extremities than in lower, but diastolic pressures are same in both upper and lower extremities in coarctation of aorta, is what you need to remember. With regard to the heart sounds, you should remember, whenever pregnancy is there, whenever there is a hyperdynamic circulation, you may hear a third heart sound. Fourth heart sound, typically when do you get? Whenever the ventricle is undergoing diastole from the atria, last 1/3 of diastole may atrium actually contracts and pushes the blood into ventricle during the last 1/3 of the ventricular diastole. But at the time, if there is any hypertension, if there is any left ventricular hypertrophy, if the ventricle is non-compliant, then the atria need to use a lot of pressure to push the blood into the ventricle, and that lead to fourth heart zone, which is a sign of a impaired ventricular compliance, is what you need to remember. Similarly, third heart zone is a sign of ventricular failure. Fourth heart zone is a sign of atrial failure, because the left ventricular compliance is decreased, is what you need to remember. Whenever there is any coarctation, it can lead to secondary hypertension. Even if you repair the coarctation, also elevated BP will not return. There's an increased incidence of cerebral berry aneurysms in these people. So these are all the true statements that need to be remembered. So now, doctor, and where is the narrowing of aorta? It is distal to the origin of the left subclavian artery. So whenever the arch of aorta is arching and you get the aorta, descending aorta, left subclavian arise. After its arisal, the narrowing occurs. So typically in coarctation, the narrowing is distal to the origin of the left subclavian. So Ravinder Singh is asking, sir, is there any mnemonic to remember Barter, Gitelman, Gordon, and Liddell? You already remembered those four itself means you are really good. There are 5-6 points about each of them. Understand their pathophysiology. You don't need any mnemonic. But otherwise, you can remember loop diuretics lose calcium into urine. Thiazide diuretics retain calcium. So, among the Liddell, Gitelman, Gordon, Barter, which is like taking loop diuretic, which is like thiazide diuretic, you need to go back and review. We have a beautiful video where we discussed all these things in this core learning app. Mid or late systolic click. Whenever there is any MVP, myxomatous change of the mitral valve, there is a mid or late systolic click. With regard to the coarctation of the aorta, strong arterial pulsations are seen in the neck and suprasternal notch. There is a 3 sign along the aortic shadow on a PA view of the chest. And there is a gradient of the upper end and lower end systolic BP more than 20. That's what you need to remember. S1 followed by a rough systolic murmur and a fixed closed splitting of A2, P2, and P2 is louder than A2. Where do you get it? So wide fixed split is a feature of ASD, and a loud P2 is a feature of pulmonary hypertension. So it is ASD with pulmonary hypertension, which is called Eisenmenger's complex, is what you should remember. Now, doctor, rough mid-systolic murmur followed by a split second heart zone with a loud P2. Where do you see? Whenever there is any pulmonary hypertension. Pulmonary hypertension, there is a loud P2. Rough mid-systolic murmur is what you need to remember. Whole systolic murmur, no S1, no S2, only murmur. Followed by S3. Where do we see that? Whenever there is any congestive heart failure, that lead to a holosystolic murmur and a third heart sound is what you should remember. Peripartum cardiomyopathy. When do you suspect? Whenever the fourth heart sound is there, that means the left ventricle is not compliant, which occur Peripartum cardiomyopathy is what you need to remember. So that's the reason any S3 in pregnant women, many pregnant women, you see S3. It's physiological. But S4 in pregnant women means it is very ominous. It means to say there is a peripartum cardiomyopathy. S1, non-ejection click, late systolic murmur in S2. They're all the classical features of mitral valve prolapse. Innocent murmur, it is short, it is soft, it is diminished in upright position and most frequently heard in the thin individual is what you should remember. Holosystolic murmurs usually represent, if maximal at apex, mitral regurgitation. Zzz, zzz, zzz. No S1, no S2, only zzz, 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 which will be maximal at the apex or in the axilla is what you should remember in MR. When hypertension has been present in older individual, what is the finding which is typically seen? Typically, when hypertension is present, short aortic ejection murmur is what you see whenever hypertension has been present. So short aortic ejection murmur with a preserved A2, they are very common in older people, especially when hypertension has been present. Murmur with palpable vibrations, thrills, is always significant, except generally whenever thrill is there means it is a organic murmur, except in aortic stenosis. So, except in VSD. In VSD, there is a high gradient between LV and RV. So that is the reason presence of thrill with a murmur generally is always clinically significant, except if it is a diastolic murmur or if it is a systolic murmur seen with VSD. Systolic murmur of VSD also, thrill may be there, but that is not suggestive of very ominous nature is what you need to remember. High-pitched diastolic murmur, what does it imply? High-pitched diastolic murmur, it implies aortic regurgitation, VSD, pulmonary regurgitation, pulmonary hypertension. They're all the features of high-pitched diastolic murmur. Whereas mitral stenosis is a low-pitched, rumbling, lub dub drr, lub dub drr, lub dub, lub is S1, dub is S2, lub dub drr, lub dub drr. That's what you listen. Whenever there is any mitral stenosis, it is a low-pitched rumbling is what you need to remember. Now, doctor, holosystolic murmurs which are heard best at the apex, followed by S2 and then S3, where do we see? Typically, we see in holosystolic murmur is the feature of mitral regurgitation, causing heart failure. That's the reason you are also able to see S3. Only holosystolic murmur means MR. A blowing holosystolic murmur preceded by S1, followed by S2, and an increase in loudness with inspiration. That means it is a right-sided murmur. That means it is a tricuspid regurgitation is what you should remember. Blowing to rough grade, 4/6 holosystolic murmur, It is a feature of VST. It's a rough grade 4 by 6 holosystolic murmur in VST. The loud P2 followed by rapidly attenuating early diastolic murmur. Always early diastolic murmur. Lub, dub, lub, dub. If you hear it, typically along with the loud P2, think about pulmonary regurgitation because of the primary pulmonary hypertension. Loud P2 is suggestive of primary pulmonary hypertension leading to pulmonary regurgitation. That's the reason early diastolic murmur, which is rapidly attenuating, is typically heard. With regard to the aortic regurgitation, there is a wide pulse pressure, diastolic murmur along the left sternal border, hyperactive, enlarged, hyperdynamic left ventricle will be seen. And typically it is asymptomatic until middle age. So ECG shows LVH, radiograph shows LV dilatation, echo is diagnostic is what you should remember. So every day we have 100 MCQ discussion, doctor, across the year, 365 days. And that gives you a lot of opportunity to do the revision with Dr. Murli Bharadwaj. Today only be part of our WhatsApp study group and prepare with Dr. Murli. What are the causes of aortic regurgitation? Rheumatic fever, infective endocarditis, congenital bicuspid valve, they are all the features except SLE. So, ankylosing spondylitis among the rheumatological disorders and Reiter syndrome, they are known to lead to development of aortic regurgitation. The amount of left ventricular hypertrophy, it is highest and greatest when there is AR. So both AS and AR can cause left ventricular hypertrophy, but AR causes a greater amount of left ventricular hypertrophy because both the preload is increased, afterload is increased whenever there is any chronic aortic regurgitation. For a lot of days, the only sign that you see in a chronic aortic regurgitation is a soft aortic diastolic murmur. Only when it becomes severe, only when AR becomes severe, then you see collapsing pulse, wide pulse pressure, Austin Flint murmur, which is mid-diastolic murmur of rumbling nature, similar to MS. Whenever there is any severe AR is there, then you get Austin Flint murmur. Now, what are the most frequent symptoms of aortic regurgitation? Always aortic regurgitation, think of in the people who present with exertional dyspnea. LV failure is a very late event. Now, which murmur is in aortic regurgitation, doctor? It is an ejection systolic murmur, which is not seen. Ejection systolic murmur is a feature of AS, not AR. So, mid-systolic murmur, musical early diastolic murmur, Austin Flint murmur, which is the mid-diastolic murmur, they are all the features which are seen in aortic regurgitation. When do you want to operate a case of aortic regurgitation? So, you should know all the criteria. Large stroke volume is not necessarily an indication. But the moment at the end of the systole, when the LV volume is increased, end systolic LV volume, that becomes an indication of surgical intervention in chronic aortic regurgitation. In chronic aortic regurgitation, Muset sign is a pulse. Quincke's sign is a nail bed capillary pulsation. So the pulse has a rapid rise and fall, which is called Waterhammer's pulse or Corrigan's pulse. Similarly, to and fro movement over a partially compressed femoral artery is Derosius sign. And a head bombing with each pressure is Musset sign, which you have to be very, very sure about. Doctor? So, the whole morning, it is always a hectic day with loads and loads of patients, intensive care unit work, some patients collapsing, some patients waiting in queue for their investigations to be reviewed, and many undiagnosed diagnosis. Physician is like a Sherlock Holmes. So I always pray before I go to hospital, I should get a chance to do the revision with you. And if I cannot, at least before I go to sleep, at the end of the day's work, when I come back to home, to sit with you, but at least to discuss some questions. So that is the whole idea. So every day studying a little with little benchmarks, solving 100 questions. That is how you become topper, doctor. Count on me. I'm there with you every day. Let us study together. There's a 1200 pages notes in which 50,000 high-yield facts I have created. Today only order for the notes. We will courier to your home. And that is more than enough. 200 out of 200 questions in NEET PG come from the 1200 pages notes that I'm going to give you. What is wrong about chronic aortic regurgitation? Austin Flint is a sign of severe aortic regurgitation, doctor. It doesn't occur in early, it only occurs in late stage of aortic regurgitation. Apical impulse is hyperdynamic. Apical impulse is prominent and laterally displaced. Aortic diastolic murmur is usually high-pitched and decrescent. With regard to acute aortic regurgitation, typically the first heart sound becomes inaudible whenever acute aortic regurgitation is there. So LV failure lead to pulmonary edema and it develops rapidly, and the diastolic murmur is shorter. Pulse pressure may not be widened like in chronic aortic regurgitation. And the mitral valve, whenever acute aortic regurgitation is there, close prematurely even before systole is initiated. And the first heart sound is, that's reason, diminished when there is an acute aortic regurgitation. With regard to the aortic regurgitation, mild regurgitation on color Doppler is not uncommon in normal people. A lot of people will have AR. Cardiac catheterization is not needed in younger patient who is showing a mild AR. And you need to do serial follow-up of the LV size and function to determine what is the critical time for the valve replacement is what you should remember. With regard to the chronic AR, ACE inhibitors are indicated when the LV diastolic size is increased in chronic aortic regurgitation to more than 5 centimeters. Acute AR increase the afterload to the heart. Aortic regurgitation increase preload and also afterload. Both of them are increased by the aortic regurgitation. And typically, beta blocker therapy, if you give, it will slow the rate of the aortic dilatation in Marfan syndrome. And that results in increase in diastolic time, amount of regurgitation per beat, and increase the volume overload on the heart. So they're all the facts that need to be remembered. Valve replacement. Where is it indicated, doctor? In aortic regurgitation, what is the criteria? Whenever aortic regurgitation is there, from the left ventricle, blood is pumped into aorta and coming back into the left ventricle. Because of that, at the end of the systole, the left ventricular systolic dimension is supposed to decrease, but it does not decrease. So, if LV end systolic dimension is more than 5 centimeters, it is an indication for aortic valve replacement, is what you need to remember. Ross procedure. Where do we do? We do it for aortic regurgitation. It requires the repair of the root. So Ross procedure is moving the pulmonary valve to the aortic position and replacing the pulmonary valve with a homograft is called as Ross procedure, is what you need to remember. So what is a cardinal clinical feature of a severe MS? In severe MS, there is a PND, orthopnea, exertional dyspnea, all these things. Syncope is more a feature of aortic stenosis. So what is the triad of clinical features of aortic stenosis, doctor? Exertional syncope, exertional angina, exertional dyspnea. These three are the features of aortic stenosis. Why exertional? Because normally heart is able to pump into the aorta in spite of aortic stenosis. But when the person exerts, there is a greater demand for the cardiac output. That time this fixed cardiac left ventricular outflow, fixed obstruction which is there due to the aortic stenosis will prevent that increase from happening, and that lead to exertional syncope, exertional orthopnea, exertional dyspnea and exertional angina. Whenever the patient is having aortic stenosis is what you should remember. With regard to the mitral stenosis, always what is the rule? The rule is stenotic lesions worsen with pregnancy. Regurgitant lesions improve with pregnancy. Simple rule, don't forget. All these funda we discussed in our regular class, doctor, in the SCORE learning app. There is 600 hours of video content which is being divided into 5,000 short videos of 5-minute duration in SCORE learning app, and you can go back and review. There is 1,200 pages notes. When you subscribe with us, we courier you these notes. You get an access to this video library and you will enjoy your preparation with us. Most of the symptomatic patients of MS, they have a valve area less than 1.5 centimeters square. If the regurgitant murmur is audible, what is the treatment of choice? In a case of MS, the moment MS plus MR is there, then we need to do valve replacement. Rheumatic mitral stenosis, of all the features, what are the most characteristic finding, doctor? Most characteristic finding, opening snap followed by S2. That's called A2OS gap. The shorter is the A2OS gap, the more severe is the MS. The presence of the opening snap and the S2 is the most characteristic finding of rheumatic mitral stenosis, is what you should remember. With regard to the auscultation in MS, the duration of the diastolic murmur has no relation. Diastolic murmur is low in pitch, it is rumbling. They're all true. Interval between opening snap and A2 is long means MS is milder. If it is short means MS is severe. What is the measured valve area when you call it as mild to moderate MS? Between 1.3 to 1.8 centimeters square. You call it as mild to moderate. Now, With regard to mitral stenosis, severe mitral stenosis, the valve area is less than 1, and pulmonary hypertension develops. Symptoms of low cardiac output and right heart failure are very prominent. So they're all true statements. In severe mitral stenosis, severe pulmonary hypertension develops, and pulmonary edema is uncommon. Now, with regard to mitral stenosis, in case of mitral stenosis, chronic atrial fibrillation develops. And any increase in heart rate reduces diastolic time, increases the mitral gradient. Once atrial fibrillation occurs, patient need to receive warfarin anticoagulation therapy, even if the sinus rhythm is restored. They're all the true statements. Now, if there is a systemic embolization with only mild to moderate disease, it is not an indication for surgery, but it is an indication for warfarin therapy, is what you should remember. With regard to the mitral stenosis, patients who become symptomatic, so in the case of the mitral stenosis, patients who become symptomatic can undergo successful surgery, but preferably in third trimester, not a second trimester, is what you should remember. If you want to score the mitral stenosis on echo, what are the important criteria? It is the amount of calcium in the commissure, submitral scarring, mitral leaflet thickening. They are all the important indicators. And what is an indication for an intervention when you are managing mitral stenosis? Typically, any pulmonary edema episodes or decline in exercise capacity or presence of atrial fibrillation, they're all the indications of the management of MS. And peak systolic pulmonary pressure more than 50 mm mercury is an indication for intervention. Now, in mitral stenosis, you want to reduce recurrent atrial arrhythmias, Mays procedure is done. Bioprosthetic valves degenerate 10 to 12 years. Percutaneous balloon valvuloplasty, it can be safely done during pregnancy. And if MS and MR is there, altogether it is an indication for valve replacement, is what you should remember. With regard to the mitral regurgitation, whenever MR is there, there is a pansystolic murmur at the apex radiating into axilla. Radiographs show LA and LV enlargement. Remember, pure mitral stenosis, if it is there, never LV will enlarge. Never LV will enlarge. If there is LV enlargement, means it is not pure MS. Unless there is a regurgitation, MR is also there, or aortic regurgitation or aortic stenosis is there, then only there will be LV enlargement in MS. Otherwise, pure MS will never lead to LV enlargement. Is a very important principle frequently tested in the NEET PG exam, doctor. For primary MR, when is the surgery indicated? Whenever the LV systolic diameter is more than 4 centimeters, or when the LV ejection fraction is less than 60%, then that is an indication for surgery. So in MR, typically in mitral regurgitation, what is the effect of it on the preload and afterload? MR places increased preload on the heart, but reduces the afterload, is what you need to remember. The last question for our evening discussion. So every day हम मिलेंगे, मिलके पढ़ेंगे 100 क्वेश्चंस को ऑनलाइन टेस्ट, डेली ऑनलाइन टेस्ट सॉल्व करेंगे और 100 days में 10,000 क्वेश्चंस रिवीजन होगा. Every Sunday we will have a grand test and discussion. Totally in 120 days, if you are with me, I hold your hand and make you become the winner of the NEET PG exam, doctor. Mitral regurgitation. Mitral regurgitation leads to AF. Yes. Mitral regurgitation predisposed to infective endocarditis. Yes. Exertional dyspnea and fatigue are the features of chronic MR. Yes. But chronic MR does not lead to pulmonary edema. Chronic MR does not lead to pulmonary edema, is what you need to basically remember. So with this, doctor, आज हमारा डेली डिस्कशन खत्म. रोज मिलेंगे, रोज पढ़ेंगे, एक दिन कामयाब होके दुनिया को दिखाएंगे, हाँ भाई मेरा MD सीट मिल गया. Good luck. God bless you and enjoy the preparation.